Welcome back, everyone. We're excited to continue with today's session. Please remember to use the chat function or raise your hand if you have any questions during the Q&A portion of the presentation. Let's get started with the second session. It is my pleasure to introduce you to our final presenter of the conference, Dr. Marco Di Tubino Scanavino. Marco is a psychiatrist, assistant professor in the Department of Psychiatry at the Schulich School of Medicine and Dentistry, and a professor for the post-graduation program in experimental pathophysiology at the University of São Paulo Medical School. Marco will be presenting a trial on therapeutic risk management for violent behavior of psychiatry in patients. Please join me in welcoming Dr. Marco.
Oh, hi everyone. It's a pleasure to participate in this event, and I thank you for the invitation. So we will talk about this trial, the therapeutic risk management for violent behavior of psychiatry in patients, a pragmatic trial pilot study. So we need to talk about how is the reality of the inpatient violence, because sometimes I think we became so accustomed to the ambient and we maybe minimize a bit of the aggressive behavior, how it happens. So we here have some estimations. So 27% is the lifetime prevalence of at least one violent act among community-treated outpatients. Regarding the prevalence of a violent act in the previous 12 months is 10%. And 56%, the recidivism rate, the patients who commit 2 or more violent acts. So the violence compromises hospital safety, increases reliance on restraints and seclusion, and inflicts a severe physical and emotional toll on nursing staff. I would say that definitely there is a tension in the ambient, not just in the inpatient, but in the clinics of mental health. And when you start observing the data about violent behavior, you realize that it's more frequent than you usually considers. So this is a very interesting thing that we should start thinking about, from a reactive coercion to a proactive collaboration. So I would say that this is the innovative piece of this trial. So let's start remembering this case law, Tarasov, that was in 1974. It was a murder. It was a young lady that was murdered. And it caused a change in the rules because the murderer told to the psychologist his plan to murder the lady. The psychologist advised the authorities, and the authorities talk with the patient of the psychologist, and he just dismissed it. He denied it, and he was very well organized and rational. And then they didn't do anything. 2 months later, the girl was murdered. So the lady and her family didn't receive any warning about that risk. So it made to change the law, and coming from some more, I would say, considering the safety of third parties. So let's think about that the traditional management for violent behavior is more reactive. In terms of strategy, we have the pharmacological interventions, we have the seclusion, the physical restraint. And in our approach is non-pharmacological, is functional and works with the chain analysis. So I would say that this approach, the proactive collaborative approach, is, I would say, a step further um, in the care of third parties uh, when we consider the risk for violent behavior. The locus of control in the traditional management is more staff directed and imposed, while in this approach is more patient collaborative and self-directed. The timing in the traditional management is more reactive to the target behavior, and then this intervention is proactive disruption of preceding node. And in terms of patient impact, the traditional management compromises the patient autonomy. And in this intervention, the TRMV approach, we will foster the autonomy and skills building to prevent violent episodes. So it's also important to consider that the risk uh, are composed for several risk factors. So it's very challenging to assess, but for sure we need to have some grounds and assess our patients based on that. So in terms of static risk factor, those are not modifiable. We have the demographics, so male gender, young age, low educational attainment, unemployment are all demographic risk factors. Clinical history, previous violent events. So this is the strongest predictor. So in my clinic, since I started studying this behavior, because I'm conducting this study for inpatient psychiatry. However, I also working on this module on my outpatient clinic in Victoria Hospital. And so I needed to be more focused on the history of violent episodes, violent behavior, and it's much more usual than we think, and it's the strongest predictor to a reincidence and new episodes of violence. Another data regarding clinical history is the early age at onset of psychiatric treatment. And some diagnoses are more associated with the risk, like schizophrenia, psychotic disorders, personality disorders, mental retardation, and bipolar disorders. And regarding comorbidities, the substance use, abuse history, and polysubstance involvement are also static risk factors. Regarding the dynamic risk factors, we consider here more those warning signs. So if you can observe or the patient can report flushed or pale face, sweating, shallow rapid breathing, trembling, pacing restless, repetitive movements, clenched fists or jaw, and also some interpersonal cues like exaggerated gestures, changing voice volume tone, avoiding eye contact, and violating personal space. So when when we have other directed violence behavior, we should understand that there are some kind of stimulus that can facilitate it still happening. For example, escaping aversive emotions like yelling reduces the unbearable internal experience of sadness, vulnerability, or hurt. Ending aversive interactions, for example, physical aggression results in staff backing down or the end of an argument. Gaining desirable experiences, for example, fantasizing about violence, creates an artificial sense of control or excitement. And gaining attention or power, like threatening behaviors, results in peers validating the patient or a partner crying, submitting. So the other directed violence will persist as long as the consequence increases the likelihood of future other directed violence behavior. So uh, beyond the warning signs, beyond the vulnerability, we also need to take a look on the consequences, the result of the behavior, and also try to understand the meaning of that behavior to the patient that can reinforce other episodes. So, making the invisible legible. So, the violence is rarely a spontaneous outburst. It's the end result of a structured, legible chain of events that can be mapped and interrupted. So, we talk in our intervention about the chain analysis. So, we try to work with the patient to have a better understanding the sequence of events that provoke the target behavior and what are the consequences. And then we have some opportunities to interfere and prevent the escalation of the behavior. So those are the chain. It starts with the vulnerability factors, the prompting event, the warning signs, the target behavior, and the consequences. So let's start with the vulnerability factor. So it means the baseline susceptibilities like poor sleeping, isolation, substance withdrawal, and any other factors that can bring some vulnerability to a violent behavior. And then a prompting event can be a trigger like a denied request, an argument, or feeling humiliated. So the sequence is the escalation, emotional and physical, that can express by warning signs. So we have the warning signs, and then it indicates a probable target behavior, a violent behavior like yelling, throwing objects, physical assault. And then the consequences that can reinforce the behavior, such as feeling a temporary rush of control. So let's consider an example. So in this example, it's a 38-year-old veteran that lost his job. He was presenting sleeping deprivation and missing treatment and stopped medications. So those are all vulnerabilities. And then he had an argument with the girlfriend over a bill. And she told him to leave the house. So he was feeling hurt, betrayed, and he was drinking at the bar and then sending an unanswered text to her, and his anger was escalating more and more. So he make a decision and encouraging a violent behavior, beating on the door of at her house, screaming threats like "I'm going to kill you both," because he was jealous, suspecting that she has an affair. And the consequence is the girlfriend crying and promising forgiveness. So we can consider it as an external positive reinforcement of gain control and a temporary escape from feelings of sadness that would be internal negative reinforcement. So considering the chain, we can have some opportunities to work with the patient. So this is something that we do in the intervention, right? We work with the patient to work on these opportunities to break an escalation of a violent episode. So, for example, regarding vulnerability factors, we can work on good sleep hygiene, securing medications, removing alcohol from the house. Regarding prompting event, practicing interpersonal effectiveness skills, choosing to wait until calmer to discuss views, for example, in that case. Regarding warning signs, we can recommend applying an ice pack to the face so the patient can experience a physiological reset, or we can recommend going for a run, going for a walk, listening to guided mindfulness are all options. And when the warning signs are not prevented or interrupted, going to the target behavior is it's much likely to happen. And regarding the consequences, what we can do, we can work on values-based reframing, connecting pain to values, like I feel lonely, hurt because this relationship matters to me. So you help the patient to get a kind of insight about what happened and about the feelings and the result of this. This is very important because the consequences, as I mentioned before, can reinforce new episodes. So how we suggest to work with the patients? So our intervention is to be delivered in 5 minutes meetings. So why 5 minutes? Because we know the nurses have a very demanding workload, and we don't want to increase it. So the idea is that having 5 minutes work in progress with the patient along around 3 weeks. So in the first moment, we try to establish the collaboration. Do you have a past experience with a violent episode? We could use an example. Or would you prefer a hypothetical scenario? So this is something that we can start the conversation. Why a past experience? Because it's much easier. We analyze something that happened, and then you have grounds to work on this. But sometimes the person doesn't want to disclose it because any reason. So we can work on a hypothetical scenario. And then let's try to define the target behavior. What exactly happened leading up to and during the behavior? And then we can work on the warning signs. Could you identify your anger escalating? What were your physical warning signs? And then we can work on the prompting event. What was the specific trigger in that exact situation? And we can map vulnerabilities. Is there anything that makes you more prone to aggression in these moments, like poor sleep or stress? So this is a very good I would say, warming up work because the patient can start seeing a reason to do that work, and it will be easier to go to build a safety plan. That is the goal of the intervention, is having a safety plan and working on how to implement it. The collaborative safety plan at first moment is working on the warning signs. So trying to bring more awareness about the warning signs, about the physical emotional changes that they can observe in themselves. So transferring the exact physiological and behavioral cues discovered in the chain analysis. And then, for example, like pacing, racing thoughts. Another point is the internal and external coping, internal breathing exercises, grounding techniques, rehearsed assertive scripts. I need to step away for a walk, for example. So all of these, when we go to the safety plan, if you pass through the chain analysis, it's much easier because we already know the context and what can be the skills that the patient has already, and some of them can be developed. So regarding internal coping strategies, those are the internal coping strategies, and external specific settings that can provide distraction, like quiet spaces, unit walks, something like this. And in the sequence, if the first steps that didn't work, we can go to the support network. So explicitly listing names of supportive individuals like staff or family and crisis resources must be specific and immediately accessible. So we will work with the patients about having safety plan, having the strategies written down, having the names of supportive individuals, all of them in the safety plan that easy accessible, and then they can activate the EASA 8 as a resource when needed. We conducted a systematic review, and we are observing growing movement of studies on non-pharmacological interventions, very allied with what we are doing. So from this systematic review regarding papers of the last 10 years, 21 of 29 major studies published confirming the growing efficacy of non-pharmacological approaches. So staff training, focused de-escalation, and behavioral management shows the strongest control reductions in both aggression and the use of physical restraint. And in terms of patient benefit, multimodal programs and patient-focused therapy, like the TRMV, drastically increase patient autonomy and preserve the therapeutic rapport, replacing coercion with empowerment. So the idea is that the legibility over unpredictability, we try to get it. So the violence is a sequence, and mapping it removes the chaos and can get a bit more of idea of control. Collaboration over coercion, so patient-centered safety planning builds vital emotional regulation skills. And proactive safety, a 5-minute daily investment transforms the war from a reactive environment into a therapeutic ecosystem. So this is the what we expect as positive results, right? How is our study? Very briefly. So it's a pragmatic pilot. It's an open label 2-hour randomized control trial. The first phase that we just initiate in Parkwood is just targeting the feasibility of the intervention, so it will not have randomization. So we are at this moment, we just may deliver the training. We deliver a training similar to this presentation that I'm having here with you guys. And after the presentation, of course, the presentation takes longer, is around 1 hour to have more interactions, questions and answers. And then we recommend to those nurses that attend the presentation to choose a patient just for training, even a patient that is not target to violent behavior. And then they have 2 weeks of experiential learning, and our research assistants support these 2 weeks, going to the units and offering some help, some support. And then we are following this in this right moment. And after 2 weeks, we will ask them to report briefly how it was, and also to answer a multiple choice test, very brief, to we have an idea if the training was good. This is the first part of the intervention that we are targeting, and then if was good, the training, we will start this feasibility study with 5 patients target to violent behavior, and we will follow them to see how it goes. In the phase 2, we will try to see signs of efficacy. So then we will involve as well Victoria Hospital. And we will have 20 patients under the usual care plus TRMV intervention compared to 20 patients in usual care. So the randomization is conducted using the last digit of the patient's OHIP number, ensuring a seamless process that mirrors real-world administrative flow. The data sources, primary outcome data like aggressive behavior score, seclusion events, are collected through resident assessment instrument, mental health, which is part of the routine administrative staff reporting in Ontario hospitals. Okay, so why we are using these data? Because we plan to escalate the study throughout Ontario. And that's the reason in parallel, we are studying the ICS data, the outcomes that we want to work on the trial to see the quality of the data. And for our pilot, we are connecting with those staff members that apply the resident assessment instrument to get the data in advance, because it's a very small sample to the pilot. So we will not need to wait until the data is available on ICS. So the pilot objective. So the first phase is to assess feasibility indicators such as patient adherence. We will consider adherence enough if 60% of the patients go through the nine steps of the whole intervention. We have a first step is the chain analysis work. We have more 5 steps is the safety plan working. And we have more 3 meetings with the nurse to try to apply, to implement that intervention. And then we can consider done by the patient, that the patient got to understand and have the safety plan and the understanding on how it happens, and will be ready to activate it if just in case, if it in case it needed. Also, nurse fidelity to the protocol. We are considering it when 70% of the nurses show fidelity to the protocol, and in regarding effectiveness of the training, if we get 80% or plus of positive results. The phase 2, we will identify signals of or trends of activities and safety, comparing the 2 groups, the TRMV plus usual care versus usual care. So in terms of those secondary outcomes, we have the aggressive behavior scale, that is a measure applied by RAI. It's standardized scores ranging from 0 to 12, meaning known to very severe, management of aggression, the frequency of seclusion events, restraint use, and PRN medication, and also length of stay of the patient. During the development of the proposal, we decided also to add a measurement on the safety attitudes of perception of the nurses, and also the burnout assessment tool. So we expect that TRMV will demonstrate favorable trends in improved staff safety perception and reduced burnout. So that's the reason we decided to add these tools. In terms of fidelity monitoring, the nurses document their progress through a tailored form that is collected by the research assistant every day. Regarding implementation success, is defined by positive engagement between nurse and patient and the ability to navigate mild difficulties in progress. So we, in the form that the nurses need to fill out, we add some questions about positive reports from the patients, negative reports, barriers, and if they could overcome barriers. So all of this is collected and will be qualitative analyzed. Regarding the timeline, we anticipate a 3-week time frame for an average patient to complete all 5 steps, the 3 follow-up practice sessions, and also in the beginning, work on chain analysis. So in terms of the trial has a very positive, precise 2 framework. He scores high in several domains, such as eligibility, because it reflects real-world adult patients. The setting is conducted in routine hospital units. The recruitment is based on routine risk to harm others scores, no external incentives, and follow-up fully integrated into existing clinical and administrative workflows. So the expected impact and future directives, our immediate goal is demonstrate that it's feasible, safe, and improves the therapeutic rapport. The impact on the system provide a foundation for a fully powered multi-site randomized trial across Ontario. And the long-term goal, reduce the reliance on coercive measures and create a safer environment for both staff and patients. And I thank all the HDRN Pragmatical Trials Training Program, Dr. Amit Garg, and the mentors, Dr. Kelly Anderson, Dr. Verinder Sharma, and all the colleagues of the Pragmatical Trial.
Thank you, Marco. That was an excellent and very informative presentation. We will now move into our final panel discussion. And joining us, we have Gary Johnson, who is a clinical nurse and manager at Parkwood Institute for Mental Health in London. We have Dr. Bushra El Hussein. Just to mention that Dr. Bushra was not had some technical difficulties joining the call, so we are hoping that he has been able to join the call at this time. But Dr. Bushra El Hussein is a consultant psychiatrist for patient services at Victoria Hospital in London. And we have Dr. Bin Lau, who's a senior biostatistician and postdoctoral fellow at Western University. As a reminder, our panel discussion will be followed by an audience Q&A, and you can post your question in the discussion, and I will bring them to the panel's attention. Thank you very much. Over to you, Gary and Ben, to begin our discussion today.
Thank you, Ben. Did you want to start?
You can go ahead, Gary.
Okay.
Thanks.
Thank you for inviting me to the panel today. And Dr. Scanavino, thank you for including us. As Dr. Scanavino said, we are just starting. We've done a lot of prep work and behind the scenes work with the staff, getting them prepped. We've just gone through some of the training to make sure we have a unified front moving forward so that we get some good results. And we were going to have, as he said, a trial of small number at the start. Just to see the feasibility of that. We're just prior to doing that right now. But the rollout from both Dr. Scanavino and his assistant have been really helpful, quite easy to comprehend, and the nurses are taking it forward. So I think we're well prepared to start that right now. And it'd be interesting to see how much of an effect this does have in a proactive manner.
Okay, thanks, Marco, for the great presentation. I know I was a bit involved in the study, but I'm glad to see a lot of the background and all of the chain analysis about this, and then all the efforts to break the chain for violent behavior. So I think it's good to it's vitally important to have interventions that's preventing these violent behaviors and improve safety for both patients and the health providers. I think that's a great area to work on. So one comment I like about this trial here is that, like, you started with the efficacy of the intervention, like similar interventions in literature, and then it shows the efficacy, and then now you're investigating the effectiveness of it in the real world setting. So that's usually, like, I think a sort of prerequisite of a such evaluation of the intervention is that there has to be a demonstrated efficacy in the ideal setting, so that you may see some in the real world setting. So that effect of the intervention in the real world setting is usually diminished compared to the efficacy, because that's the real world situation. So I think that's a great work there. Yeah, so I'm happy to. So there are some questions, but so maybe I can ask a bit later if we're in that section yet.
Dr. Scanavino. Oh, apologies.
Yes, I think I can make a comment regarding the both comments from Jerry and Bean. That for me, it's when I started working, on Victoria Hospital site, and they offer me to work to providing assessment for risk for violent behavior. However, I'm not a forensic psychiatrist. So I look for a clinical management to work on this. And then I found this intervention on doing a literature review. So mainly the papers from Wordfill that frame all these steps of intervention is not something new because basically they adapted the intervention that is already very known to individuals with risk for suicide to aggressive behavior. So, but what I want to point out is that it's something to be useful for the clinic, for the clinicians, that because this was my position in the beginning, because I say I'm not a forensic psychiatrist, and I don't want to go through. Oh, I will do assessments to say who is responsible or not for what they are doing. No, my target is providing clinical care to the person. So when in the ambulatory, when my colleagues are referring patients to my clinic, I first say, okay, please advise the patient what we will work on, and that is a voluntary work to become better to prevent episodes. So because over there is another setting, and I can say this in the beginning. So uh, and then we are bringing this for the inpatient. And then I think since the literature review that we are conducting, as being mentioned, are saying, okay, the intervention, non-pharmacological interventions are positive. And I would say that this intervention, particularly that is more preventive than therapeutic, can be something, some plus to the tools to deal with this issue on the inpatient psychiatry. Yeah.
Dr. Scanavino, I see that Dr. Bushra El Hussein has as well been able to join us. Welcome, Dr. El Hussein.
Hi, yeah, thank you. And sorry about that. I didn't get the passcode and I checked the email later. So sorry about that. I think I missed most of the talk, but just when I joined, I think Marco, you were trying to address the gap and the difference in how is this study is different from what we're doing currently in the inpatient. Yeah, I think you did cover that part, right?
Yeah.
Okay. And
so maybe I can take advantage of what you are targeting now, because I think this is something that I didn't tell the audience. What is the usual care and what is the difference to our intervention? I think this is what you are mentioning, right, Bushra?
yeah.
So the usual care, and Jerry can say this better than me, but I will summarize. The usual care there is already in place a lot of care regarding violent behavior. The nurse staff is very well trained to identify potential risks. So the first thing is, since the patient is admitted, they always know, they always investigate if there is a history of aggressive behavior, or if they are presenting any kind of warning signs. If there are history or warning signs, those individuals will be targeted, will be flagged at risk for violent behavior, and the nurses will follow those individuals every 12 hours to take a look if there is any kind of warning sign they need to have more attention or not. But they will stay assessing those warning signs every 12 hours. And if the individuals present a violent incident, then they have a very structured protocol to intervene and also go through to minimize any kind of risk of more aggressive behavior. And they also prepare a safety planning for the patient in the beginning through an interview. So this is the usual care. So our intervention it will be a plus working on the safety plan, since working on the chain analysis through analyzing a bit the behavior, the vulnerability factors, the prompting events, and the result of a violent behavior, and make the patient more ready to implement the safety plan. So I think the intensity and consistency of the approach makes a difference to compare to just usual care.
Dr. Scanavino, it seems like you have designed this to have minimal burden on the nurses' day-to-day activities. I'm wondering what is the feedback that you have been experiencing from the nurses that have started to apply this approach into their routine?
So I would say for you, based on the two meetings that we had here in Parkwood and these first 10 days that we are observing, my feeling that they are very, I would say, helpful, and they have openness to start a new approach and doing more a bit more work beyond what they already do. But it's something new, and something that we are measuring in the feasibility is how much our training is okay is enough. So if we need to do a one more meeting, or what we need to do to help them and to really, I would say, sensitize them about the relevance of the situation. And you know that because it's a pragmatical trial, and we are trying to do a very open ecological study, right? In the real world, they have a lot of things to do, and they are, I would say, demands of the everyday job have different patients. So we cannot expect that will be like the report that I show you right now, the presentation, right? But it's a learning for all of us, and our idea is try to get the best intervention possible that can be helpful, and in the end can be less work to them and a better environment perception.
Thank you.
Yeah. I don't know if Jerry and Bushra would like to add anything about this.
I can add some perspective from the nursing as well. Like Dr. Scavino mentioned many things, which is true. I think the identifiers that we would look at from the nursing perspective is people usually come with a BSA, so behavior safety alert, and that follows the patient. So it already gives us a history. Excuse me, as Dr. Scanavino said, the best indicator for future is the past. So we take a look at that, look at the incidents which caused those things. Many of the things that Dr. Scanavino had said, whether it's substance use, diagnoses, psychosocial events, so those types of things. So we're already there. Our safety plans, if the patients have those, already identify what they're bringing to us, so the nurses are well aware to make their observations a little bit clearer. Care plans, whether they're in place or developed, certainly are a fluid document, so they continue to provide things for the nurses to follow through in. The identified risks that the people bring to us certainly is brought to upon admission. And, most of our patients we know from many admissions, so they bring those forward as well. And then our regular rounds, and I don't mean interactive rounds with the whole team, but our hourly rounds that we do, and monitoring of the patients that, I guess when your spidey senses are tingling, you pick up on those things, right? So the longer you work, the more you see those things. As for the training, nurses have complimented the ease of use because it was quite simple, quite formative. It's like 5 minutes. Here are your questions. So we had a narrative sheet that all the nurses used to guide them forward, and a rationale for why we're using and asking those questions. Explaining it both to the patient and the nurses is very helpful, so that then we can get a lot more buy-in from both sides. And I think the rationale overall is a safer work environment because we have less incidents, and it's something that's not too time and not time too controlling, because as we know, nurses are busy, and that was brought forward right from the get-go from Dr. Scanavino and his research assistant, that we have to be aware of that or we're not going to get buy-in. So I think that was all taken into account.
Thank you. I am going to jump into the questions that we have from our participants today. So I have 2 questions from Dr. Ahmed Garg. The first one is a little bit of a cheat question, and I'll start with that one. So a determinant/chain of violence was quite interesting. I was contemplating what was the chain behind Will Smith slapping Chris Rock at the Oscars. So I'll leave that at that. Dr. Scanavino, would you like to address that, or should I move forward with the second question?
Yeah, well, this is a tricky question. I think that, people in the gossip world mention some things about the wife and the joke that was done. I don't know. I was so surprised at what happens. I really think that something else happened because he lost his control. So
Thank you for that expert opinion. And the second, more serious question, also from Dr. Garg. Given that there is an expected proportion of patients who will not be adhering to the intervention, around 40% estimate, which will diminish/dilute the intervention effect, should the aim be for the nursing fidelity to be over 90% adherent to the protocol?
this is a good point. As far as I understand, the idea would be increasing the fidelity of the nurses to try to get more than 60% of adherence of the patient. Yeah, let's see how feasible is, right? Let's see how feasible is getting the 70% or if you can go higher. But I really appreciate this idea because I didn't think before. So thank you. Let's think about this, and maybe we can get a better adherence in the end of the patient.
Thank you. Bit?
Well, yeah, thanks for the question. So I guess it's a question section now. So I have a couple of questions, Marco, about the trial. So one thing is about the intervention delivery. So you said there's like about 3 weeks in time frame to deliver the interventions, but then there are some mental health patients that got inpatient stay for maybe a very long time period. For example, they can stay for a year. Is there any other continuous support of the intervention after that initial 3 weeks, or is that 3 weeks sufficient for a patient no matter how long they stay? That's maybe question one. Another question is that for the outcome assessment. So one of the outcome is the ABI score. So I know it's in the administrative health database, but who's recording that score? Who's giving that score? I know it's an ordinal outcome, but is that scoring subjective or is that an objective score? So if the health care provider who's providing the intervention is also some of them, maybe the outcome assessor, there could be potentially some bias in there. Yeah, there's those two questions. Thanks.
Okay, so good question. So I would say that 3 week is an estimated good time for the to do all steps of the intervention. I consider, based on what we already studied, that it's enough even to a long-term stay on the hospital. You should consider that, for example, when we plan to work on these in different settings, for example, we start here in Parco, the patients stay longer. Victoria Hospital is much shorter time. I think 3 weeks would be a good time to accommodate intervention that we can escalate further if it's successful, if the trial is successful. Definitely, if it is enough for long term, I don't think we have this goal right now, but it maybe can be a very good point for another phase of our studies. Regarding who is scoring, this is a very good point because we identify two different types of assessing the RAI in the both hospitals. One of them is a group just committed to do this, but they go through the notes of the nurses. And the other hospital, the staff that assess and record the information. So the first one said they will also change for the staff starting recording this intervention. And we think it will be better, even having the risk of bias, because they can sometimes be the who is providing the care, but at least we will have a good inter-rater reliability on how to assess. So, and it seems the standard in the Ontario hospitals to the staff get and get this information, collect this information.
Thank you, Dr. Scanavino. We are at time. I'm sure many of us would like to continue this conversation. It is very interesting. But thank you again to all of our panelists as well, and to all of our participants and attendees joining the Canadian Pragmatic Trials Training Conference. We have had an exciting, innovative, engaging 2 weeks, and all of the videos will be posted on the Pragmatic Trials website and, from what I understand, on YouTube as well. If you have any questions, of course, you can add them to or message the presenters directly with any specific questions. And you can provide feedback to the Pragmatic Trials Training at uwo.ca email address anytime. Again, thank you for joining us. Have a lovely rest of your day. And it was wonderful to have you here today.